Through this presentation, I will be reflecting on my Capstone simulation by focusing on phases 1, 2, 5 and 6 of the BAS model of holistic reflection. I will aim to improve my critical thinking and clinical decision-making skills while also linking my reflections with experiential learning, human factors, and clinical debriefing lecture topics. Experiential learning involves learning from experience, gaining knowledge, and insights through active participation. The objective of experiential learning is to apply theoretical knowledge to practical situations, allowing the individual to contemplate, question, and act based on their experiences while incorporating their newfound insights. Through this process, learners enhance their critical thinking capacities, refine their clinical skills, and foster a reflective approach to their work. Being involved in one of the Capstone simulations and utilizing the BAS model of holistic reflection allows for this experiential learning experience. Self-reflection is an imperative learning tool within the tertiary education system, as it can aid in the development of accountable and autonomous future clinicians while ensuring continual patient safety. Firstly, let's summarize all elements of the base model of reflection. The model uses an integration of 6 phases, which are designed to promote critical reflection at a personal and holistic level. It is a holistic continuum incorporating self-awareness, critical reflection, and reflexivity. There are 6 phases within the model. In Phase 1, individuals tap into their self-awareness. Phase 2 focuses on descriptive recounting, equipping learners to observe and determine essential factors for later reflection. During Phase 3, individuals delve deeply into their own and others' emotions, thoughts, and actions. In Phase 4, learners holistically evaluate the experience, linking it to prior knowledge to understand the events and their critical influences. Phase 5 involves a thorough analysis of successes and unexpected outcomes. And lastly, Phase 6 sees learners synthesizing insights, strategizing, and setting future goals. The aim is to apply these learnings to real-life situations, bolstering their professional capabilities. Over 2 weeks, 12 scenarios were randomly presented, emulating real-world unpredictability in tasks. This method, meant to mimic unexpected real-world challenges, made me uncomfortable. The unpredictability and limited preparation time left me feeling ill-prepared during the first week. Several rooms were decorated and student actors were utilized to heighten the realism, enabling a deeper engagement in the simulation. In the initial week of simulations, I was recovering from a cold, leaving me feeling unclear and mentally clouded. I improved my time management in the second week and felt better prepared for the assessments. Preferring to participate early to avoid rising anxiety, I reminded myself that mistakes now would offer lessons for future situations. When it came time to lead the simulation as the primary officer, I initially felt overwhelmed and uncertain of where to start. However, after just a couple of minutes, I focused on maintaining composure, acting professionally, giving clear directives, and coordinating with the team. Phase 2 calls me to descriptively recount my experience. Here I reflected on leading an outdoor simulation of a traumatic incident involving a cyclist and a car. Surrounded by 10 peers and a teaching assistant, I managed the scene, treating the patient and ensuring safety to myself, colleague, and bystander. Feedback was given on my performance and timing of interventions. Before starting, my secondary officer and I strategized our approach. In the scenario, I prioritized initial assessments and addressed traumatic arrest reversible causes. Post-simulation feedback highlighted areas for improvement, such as quicker pulse checks, treatment sequencing, prompt airway support, and correct splint application. As Phase 5 requires an evaluation of what succeeded and what faltered, I will be analyzing various human factors to assess the simulation experience. Human factors delve into the relationships between people, technology, and the environment they operate in. These factors can either enhance or compromise patient care and safety. This is particularly prominent for paramedics, who are frequently faced with unexpected, sudden situations and are expected to perform in any circumstance or environment. Some human factors can be seen listed on the slide. The factors underlined are what I'll be focusing on during my presentation. The Swiss cheese model, or the error chain, is not usually a single event, but rather the cascade of failed or absent barriers which can lead to a major error occurring, such as significant patient harm. This chain is often expedited through poor decision making. Decision making is the process of creating choices, picking the most suitable one, and then communicating and executing that choice. Upon re-evaluating my simulation experience, I mistakenly prioritized internal hemorrhaging under circulation before turning to airway and breathing. This led to an improper sequence of the primary survey. In retrospect, I should have delegated the management of internal bleeding to my secondary officer and prioritized ventilation for myself. This error led to a delay, resulting in an arrest, which necessitated a shift in my approach. Additionally, I stepped in when my colleague had trouble with the retraction splint, causing further delay also. While we did address reversible causes of the traumatic arrest, this string of minor missteps and decision-making errors culminated in an undesired outcome, a cardiac arrest. Clinician cognitive load refers to the amount of mental effort required by clinicians to complete a task. If one experiences cognitive overload, it can lead to being overwhelmed, information being lost, clinical errors, and can negatively impact patient safety. To reduce cognitive overload, checklists, CPGs, training, support, and simulations can be utilized. Through previous studies, I have had multiple opportunities to deepen my understanding of the CPG management of a traumatic arrest. I found that this deep, previous knowledge assisted me during my simulation, as it made the process of applying such CPG more instinctual and easily recalled. For optimal performance, a team requires a member to step up as the leader. Leaders are proficient in setting and upholding standards, assisting team members, and managing stress. In this context, I, the primary officer, assumed this leadership role. Leadership can be categorized into two styles, directive and empowering. In trauma scenarios, an amalgamation of both leadership styles proves beneficial. Research indicates that effective leadership correlates with improved patient care, thorough secondary surveys, and detailed planning. Conversely, an absence of leadership can result in mistakes and task delays. Reflecting on my simulation, I believe I demonstrated strong leadership skills through effectively delegating tasks, keeping composure, and maintaining consistent communication. By positioning myself at the airway, I could oversee the entire scene and minimize cognitive distractions. A testament to my leadership efficacy was my secondary officer's feedback during the debrief, mentioning that my presence had a calming effect despite their internal stress. Effective teamwork and communication are pivotal in ensuring high quality and safe patient care. A harmonious collaboration, mutual respect, and transparent communication are the foundations of successful teamwork. Proper teamwork minimizes the chances of errors or harm, ensuring patients receive efficient and timely care. Communication challenges can arise from misinformation, misunderstandings, or an overload of details. To combat miscommunication, strategies such as echoing received information, active listening followed by response, or implementing a closed-loop communication method can be adopted. Relating this back to leadership, I ensured that clear directives were given to the secondary officer and bystander. I frequently checked in with them and evaluated if roles changes were necessary, especially to reduce compression-related fatigue. I also had the secondary officer echo in my instructions to confirm accurate understanding and effective execution. For Phase 6 of the model, debriefing involves reflecting post-event to identify successes, challenges, and areas for enhancement in future endeavours. Studies have shown that debriefing improves patient safety and outcomes. By self-reflecting on my actions and thoughts and tapping into feedback from my colleagues and instructor, I can pinpoint areas for growth and improvement. My peers, having observed the event, offered valuable feedback on potential improvements and highlighted areas of success. The teaching assistant also contributed insights based on their past experiences. After the simulation, I feel more confident if a similar situation were to occur in the future due to the self-reflection and peer feedback. I've learnt about weighing up the risks versus benefits of different treatment pathways and deciding which has a higher priority order. From my field experience, past simulations, and my ongoing career, I've acquired effective communication techniques and applied them in the simulation. Additionally, I have deepened my grasp of the pathophysiology of various conditions and the associated pharmacology, giving me clearer insights into our treatment approaches and necessary interventions for patient safety. Overall, being involved in Capstone and reflecting, I have gained further confidence in my skills, communication, leadership, teamwork, clinical decision-making, debriefing, and management of a high acuity case.